Good morning. My name is Marie Rienzo, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to keep and support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Marie. Today's speaker is Dr. Valerie Earnshaw. Dr. Earnshaw is an Assistant Professor of Human Development and Family Studies at the University of Delaware. She's a social psychologist who studies associations between stigma and health inequities across the lifespan. She bridges stigma theory from the fields of psychology, sociology, and anthropology with research on disease prevention and treatment in public health and medicine. Dr. Earnshaw applies rigorous methodologies and data analytic techniques to her work, including longitudinal designs, social network analysis, multilevel modeling, and structural equation modeling. She has contributed to the development and psychometric evaluation of measures to assess stigma among people living with chronic illness, HIV, and substance use disorders. These stigma measures have been used to better understand the extent to which individuals experience stigma and how stigma impacts health outcomes. It's my pleasure to welcome Dr. Valerie Earnshaw.
Hello, and thank you all for joining me to think about methods for stigma research today. Just know quickly that I have no conflicts of interest to disclose today, and here is where some of my funding is coming from. Aims for today are to first review a few key concepts related to stigma. One of the challenges to stigma research can just be defining exactly what we mean by stigma and figuring out which part of the stigma process it is that we want to study. And then we'll review a few common critiques of stigma measurement and methods for research, and we'll think through some solutions. And then we'll end by talking about how to intervene to address stigma. We'll define some of the tools in our stigma intervention toolkit or toolbox and think about how to use those tools to make them most effective. Okay, so starting with our overview of stigma. So people use this term stigma in different ways, so I'm just going to spend a few moments to review a few definitions and establish some common terminology for today's talk. Now, Goffman, who was a sociologist by training, provided us with an early definition of stigma, which is that stigma is social devaluation and discrediting associated with a mark or a characteristic. Now, because Goffman used this mark or characteristic terminology, we often hear people refer to stigmas, by which they often mean these devalued characteristics. And unfortunately, we have many examples of marks and characteristics that are socially devalued and discredited today. They include physical illnesses like HIV, mental illnesses like bipolar disorder, what social psychologists such as myself, sometimes refer to as social norm violations, which might include things like minority sexual orientations and gender identities, as well as some socio-demographic characteristics like some racial and ethnic backgrounds. Today's focus will include research on stigma within the context of HIV and substance use disorders. As some of you are already thinking, wait a minute, people living with HIV and also substance use disorders also live with some of the other characteristics, identities, etc. that are listed on this slide, and you're absolutely right, and we'll come back to that later in the talk. Now, when we hear people use this term stigma, they're not always referring to a particular socially devalued group or identity. They're often talking about a broader social phenomenon. And that's really because theorists since Goffman have really honed in on this social aspect of stigma. Theorists have highlighted that stigma results from a social process. So Lincoln Phelan theorized that stigma emerges at the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination that's occurring within a power context. And ultimately, it is this social process that leads to the construction of certain marks, identities, or characteristics as indicators of tarnished character. And then these marks are used to justify discrimination toward and power loss of people with those marks. So this means that when we're talking about stigma, we're often talking less about specific marks or characteristics and more about this larger social phenomenon that results from a social process. Let's just take a moment to consider why this social process exists. Theorists have proposed that there are three primary functions of stigma, and they include to keep people down, away, and in. Keeping people down refers to exploitation and domination. So some groups in society have less power and resources than other groups, and stigma helps to perpetuate these power and resource differences. So racism and sexism are examples of this type of stigma. Keeping people away refers to the avoidance of disease. Theorists have argued that we have evolved processes to avoid people who may be infectious, who may harm our own health. So HIV stigma, Ebola stigma are examples of this type of stigma. And then keeping people in refers to the enforcement of social norms. So people who deviate from our social norms are sometimes characterized as immoral or different, and substance use stigma is an example of keeping people in, a sort of societal attempt to stop people from using or misusing substances. Now, to date, much of our research on stigma, especially health-related stigma or stigma associated with mental and physical illnesses, has occurred in sort of a siloed way. So we've had researchers studying stigma within different disease contexts without always a ton of sharing of insights between those silos. There has recently been a push to adopt more cross-cutting approaches to health-related research. So as an example, in 2017, Fogarty and NIH sponsored a workshop on the science of stigma reduction, where participants brainstormed about developing and using cross-cutting stigma theory, measures, and research approaches, as well as intervention strategies to make faster progress in addressing stigma across the board, across multiple mental and physical illnesses, for example. The meeting led to a collection on stigma research in global health that was published in February 2019 in BMC Medicine in open access. This collection further articulates the importance of developing cross-cutting approaches to health-related stigma research and intervention, and includes a few articles that specifically highlight relevant methods. Now, one of the things that a cross-cutting approach to stigma research allows us to do is to think about the processes linking stigma with health outcomes among individuals across a wide range of disease contexts. So this is a pared down or simplified version of a framework to understand this process. So you can look to the citations at the bottom of the slide for more detailed versions or expanded versions of this. But this starts with the social process of stigma that we've been talking about. And then our framework defines ways that individuals living with stigmatized characteristics experience that stigma as a series of stigma manifestations. And I'm just going to take a brief moment to pause and define these because they'll continue to come up throughout the rest of today's webinar. Internalized stigma is sometimes referred to as self-stigma and refers to the endorsement of negative beliefs and feelings associated with a stigma and applying those to the self. So this could include feeling like one is a bad person due to one's substance use. Enacted stigma is also sometimes referred to as experienced stigma, perceived stigma, or even discrimination, and includes experiences of discrimination or unfair or unjust treatment from others in the past or present. So this could include social rejection from friends and family due to one's substance use. An anticipated stigma refers to expectations of these experiences in the future. So this would be expecting social rejection if others were to become aware of one's substance use. Now, thinking with my cross-cutting approaches hat on for a moment, I would just like to emphasize that people with really any stigmatized characteristic can experience these three different types of stigma manifestations. So for example, a woman living with HIV or a man living with a substance use disorder could both experience internalized, enacted, and anticipated stigma. But the ways that these experiences present themselves might change a little bit. So the person with a substance use disorder may worry that people aren't going to trust them, that doctors may not take their complaints of pain seriously because they think that they may be pill shopping or trying to get pain medication that isn't medically necessary. The person living with HIV, on the other hand, may be more worried that people won't want to physically touch them, to give them a hug or to shake their hand. So essentially, our manifestations stay the same, or these sort of buckets, but the specific experiences may vary a bit. So returning to our figure, these experiences of stigma, in turn, are associated with a suite of mediating mechanisms. So experiences of stigma can shape the extent to which people have access to important resources, things like jobs or housing, as well as can affect people's health behaviors. They're also associated with increased stress. And then these mediating mechanisms finally can lead to worse mental and physical health. So I'm now going to talk about how to study this social process of stigma, including how to measure stigma and methods that may be helpful to study it. And I'm going to frame this part of the talk around common critiques of stigma research and how we can address them. So I'm going to focus on 4 common critiques: the conflation of stigma manifestations, ignoring sources of stigma, siloing lived experiences of stigma, and disregarding context. And again, for each of these critiques, I'll talk about what the critique is and then suggest a few solutions that we can use within our research. So starting with conflating stigma manifestations. Many of our stigma measures essentially mix up different types of stigma manifestations or conflate them within the same scale, making it difficult to tease them apart. So just as a reminder, stigma manifestations are the ways that individuals experience stigma, and they can include enacted, anticipated, and internalized stigma. Now this is a problem because when we don't measure them separately, we don't know which ones participants are experiencing more of. So it's possible that we could have someone who anticipates a great deal of stigma associated with their substance use disorder. They're really and truly worried about it, but maybe they've never experienced enacted stigma because they've never told anybody about it. They've never disclosed. And so no one yet even knows that they have a substance use disorder. If we don't measure our manifestations separately, we also don't know which ones might be leading to worse health outcomes. So we don't know, for example, if a patient isn't picking up their medication-assisted therapy, maybe their methadone, because they think that they're a bad person and they just don't want to think about their substance use disorder, or because they anticipate a great deal of stigma just going to the methadone clinic. So here's an example of conflation, and I'm using a scale here from the HIV literature, and I just want to emphasize that I don't mean to pick on this scale in particular. I'll emphasize that many of our stigma scales across all of our disease silos do things like this. So if we look at the items, we see one here that is, I felt ashamed of my illness. Now this is internalized stigma. We also see an item that says, I feared I would lose my job if someone found out. And this is the anticipated stigma. And then I have felt people avoiding me because of my illness. And this is enacted stigma. So if a participant scores high on this scale, we may not necessarily know if it's driven by a great deal of internalized stigma or anticipated stigma or enacted stigma. Now, this is actually not a terribly difficult problem to solve. We have beginner level solutions for this. We can all accomplish this solution in our research. The important thing here, I think, is just to measure these experiences of stigma independently. So we can do this by using different scales. We have, scales just designed to measure internalized stigma, for example. Or we can use one scale with different subscales mapping onto our different stigma manifestations. So as an example of this, Laramie Smith, Mike Copenhaver, Chinazo Cunningham, and I have worked on a scale to measure substance use stigma manifestations that differentiate between enacted, anticipated, and internalized stigma. So here is the scale, and I'd really just like to point out that it has items that measure enacted stigma, like family members have thought that I cannot be trusted. It has anticipated stigma, such as family members will look down on me, and then internalized stigma, like I feel that I'm not good as others because I use alcohol or drugs. In our HIV research, we have differentiated between these different types of stigma manifestations associated with HIV, and we find evidence that they are related to different kinds of health and well-being related outcomes. So in one study, we found that internalized stigma was associated with affective related outcomes, like feeling more helplessness and having less acceptance of and perceiving fewer benefits of living with HIV. We found that internalized stigma was also associated with behavioral outcomes, including having longer medical care gaps and greater likelihood of medication non-adherence. Anticipated and enacted stigma were associated with physical health outcomes in this study. Those included chronic illness comorbidities and lower CD4 counts. We thought that this made sense to the extent to which anticipated and enacted stigma may be experienced by people as stressors. And I'll just note quickly that other work suggests that anticipated stigma is associated with behavioral health outcomes, things like avoiding medical care visits. So there's still a lot of work to be done here in terms of differentiating between these manifestations and exploring how they may differentially impact health behaviors. So overall, this work, other work, does suggest that it might be important to measure these stigma manifestations separately to develop a more nuanced understanding of how stigma might undermine health. Okay, our next critique is that stigma research often ignores sources of stigma. People report experiencing stigma from many different types of people, from their family, but also their friends, their employers, their healthcare providers, and others. And it's possible that they experience both different amounts of stigma from different sources, and that stigma from some sources may be more harmful. It may be more stressful, it may be more depressing than stigma from other sources. So just take a moment to think about if your mother or your daughter didn't invite you to their holiday gathering this year versus if your neighbor, maybe the one you don't really like anyway, doesn't invite you to their holiday gathering. One of these experiences might feel quite devastating. You might really remember it if your mother or your daughter doesn't invite you to the holiday gathering. But the other experience, if your neighbor doesn't invite you, you might get over that and you might eventually even forget it. These are quotes from people in recovery from substance use disorders who were recruited from a methadone clinic in New Haven, Connecticut. And what we can see here is that the nature of stigma sounds a little bit different between these different sources. So participants are saying that family members don't trust them in the house or don't invite them over, but they're worried about being fired by employers and that they're receiving worse care from healthcare workers. We also see some evidence that the magnitude or the impact of stigma on health may be different. It looks like stigma from family members could be most hurtful depending on how we interpret the quote. This participant says, they're like the big people that hurt you. If we return to our example HIV stigma scale and we look at the item, felt people avoiding me, we might ask, who was it that was avoiding me? Again, it might be quite different if it was my mom or my daughter who was avoiding me as opposed to the neighbor who I don't really like anyway. It could be important to understand from whom the stigma occurred to understand the health outcomes of it. One basic level solution to this problem is to use subscales to measure enacted and anticipated stigma from different types of sources. So this is what we've done in our substance use stigma scale. So we focused on stigma from family members and also from healthcare workers within this scale. We tailored our items to the types of stigma experiences that people may experience from these sources based on some qualitative work that we had done. These included things like being looked down on by family members and concerns about pill shopping from healthcare workers. When I have measured these sources differently in past work with people living with a range of chronic illnesses, I've seen some evidence that people experience and anticipate different amounts of stigma from different sources and that the impact is different. So in one study, we found that anticipated stigma from family members was a more powerful predictor of stress than anticipated stigma from healthcare workers. Although anticipated stigma from healthcare workers predicted different types of healthcare-related outcomes, healthcare engagement-related outcomes. Now, I would say that the advanced move here is to use methods that can better account for relationship factors within our research. So as an example, we can leverage social network methods within stigma research. So these methods allow us to measure enacted and anticipated stigma that our participants, or egos in social network lingo, may experience from a wide range of others, or alters in social network lingo. So then, in addition to measuring and differentiating between our different stigma manifestations, we can also measure a suite of relationship characteristics. So we can ask, what type of alter is this? How close is the ego to the alter? And find out how stigma interacts with these relationship characteristics to affect different types of health outcomes. So this is actually the focus of a current project that we're doing here in Delaware. We've just finished collecting egocentric social network data with 150 people in recovery, and we'll be able to see if stigma from some alters or other types of people is worse than stigma experienced from others. So please stay tuned for more on that. Okay, next up. Stigma researchers have been critiqued for siloing people's lived experiences of stigma. Now, intersectionality theory highlights that people live with a range of intersecting characteristics or identities. These represent both dimensions of privilege or power as well as of vulnerability. The theory holds that these characteristics can lead to unique experiences for individuals, including experiences related to stigma. Stigma intersectionality theory tells us that to really understand both how stigma is experienced by individuals and how it may affect their outcomes, we should really be thinking about studying these different dimensions simultaneously and in an interactive way. Now, this is actually quite challenging because most of our stigma scales measure stigma associated with one characteristic at a time in a very siloed way, like substance use stigma or HIV stigma, including the scales I've been sharing so far today. Now, luckily, there has been a good deal of attention paid to this critique lately, and smart people have been making recommendations about what to do about it. Most of the solutions that I'm going to share for this critique are described in Janet Turan and colleagues' recent paper on intersectionality that was published as part of that BMC Medicine Special Collection on Stigma Research and Global Health. So I'm going to give a big picture overview here and then suggest that you read the paper if you're interested in learning more or really diving into methods for intersectionality research. So I'm going to review a few measurement approaches which can guide how we can ask our questions in ways that consider intersectionality, as well as methodological approaches. So what we can do with our stigma data to look at it or analyze it in an intersectional way. I'm going to review 3 approaches to measurement. The first is a generalist approach. So this involves measuring experiences of stigma in general and then allowing participants to make attributions for those experiences to different characteristics and identities. So this might be a good approach if you don't necessarily need to know why your participants experienced stigma, only that they did, or if you have a very diverse group of participants who may be experiencing stigma associated with many different characteristics. It may also be a good approach if you feel that your participants or your population might know that they've experienced stigma, but you feel that, or you have some evidence to suggest that they may always not be 100% sure why it's occurring or having trouble making attributions. So the everyday discrimination scale is probably the most widely used example of this approach. So this is a short version of the everyday discrimination scale. And you can see that participants are asked questions about their experiences of enacted stigma in general. So an example item is, you are treated with less courtesy than others. And then in follow-up questions, researchers can ask participants why they think these things happened. So they can click off, they think it happened due to their race, their gender, substance use, HIV. Sometimes researchers ask people just to choose the one main reason, and sometimes researchers allow people to select multiple reasons. Parallel scales, which is the next approach, allow us to measure stigma associated with a few different characteristics with the same items. So this can be good if you're specifically interested in stigma associated with a limited number of characteristics, like if your sample is relatively homogeneous or similar in the kinds of stigma they might experience. So the multiple discrimination scale is a great example of this. It measures stigma associated with race, HIV, and sexual orientation among Black and Latino gay men living with HIV. So let's take a look. So here are the items. These questions were repeated 3 times, with participants asked if these things happened to them because of their race, their HIV status, and or because of their sexual orientation. So example items here are treated with hostility or coldness by strangers and rejected by a potential sexual or romantic partner. Now, I think what's interesting here is that the percentage of participants who say yes changes across these attributions, suggesting that some people are attributing stigma to different characteristics, which has been a little bit debated within the stigma literature. So if we take a look here, we see that higher percentages of both Black and Latino participants are saying that they had been treated with hostility or coldness by strangers in relation to their race and sexual orientation than their HIV status. Now, this makes some intuitive sense to the extent that strangers may be able to tell someone's race or sexual orientation more easily than their HIV status. But then in contrast, higher percentages of participants said that they had been rejected by a potential sexual or romantic partner in relation to their HIV status than their race or sexual orientation. And again, this makes some intuitive sense to the extent that people living with HIV may experience more stigma in romantic relationships than other kinds of relationships due to fear surrounding HIV transmission within those sexual relationships. Another less common approach is to use scales that are tailored to the specific population of interest. So again, this is good if you're working with a relatively homogeneous population in which people are generally experiencing the same kinds of stigma. So Lisa Rosenthal has recently created a gendered racism scale that gets at the unique experiences of stigma among women of color. So here are a few example items from her scale. So one of the items states, how often do you feel that people make negative assumptions about how many sexual partners you have based on being a woman of your racial and ethnic background? So as you can see, participants are really encouraged to reflect on experiences that are happening at the intersection of their gender and their race. Now, what I think is really interesting and compelling about this work is that this gendered racism scale is actually a stronger predictor of stress than racism or sexism measured separately, suggesting that possibly a more precise measure of enacted stigma might be a more powerful predictor of some health outcomes. So this trade-off between more general scales and more tailored scales is one that researchers should consider within the purpose of their study. I think that both can be good solutions depending on the study questions. So now we're going to tackle a few analytic approaches to intersectionality research. Probably the easiest way to analyze data through an intersectionality lens is through stratified analyses. So we can look at the levels of stigma among subgroups within our samples, maybe divided up by characteristics like race, age, or something else. And this might be useful if you've used a generalist scale, something like the everyday discrimination scale, and you want to know if some groups of people are experiencing more stigma than other groups of people. So Turan and colleagues recommend these stratified approaches at the early or exploratory stages of research. Another approach is to use a moderation approach, which would allow you to determine, as one example, whether the effect of stigma manifestation associated with one characteristic might depend on the stigma manifestation associated with another characteristic, which is a bit of a mouthful, but we'll come back to an example. This is possible to do if you've used parallel measures. Here's an example of our work with substance use and HIV stigma. So here we used parallel measures of internalized stigma. So we asked the same question around stigma, but associated with both HIV and then substance use. And essentially what this tells us is that the effect of internalized HIV stigma on HIV or on depressive symptoms was strongest when participants had also internalized substance use stigma. Now, an additional approach that's been getting more attention lately is approaches such as latent class analyses. And this will allow you to identify subpopulations of individuals based on their measured stigma experiences. Here's an example from a study using the everyday discrimination scale. So using this analysis, we were essentially able to identify subgroups of participants based on their attributions for the discrimination that they were experiencing. So here, the x-axis is the attribution that they made for discrimination or enacted stigma, as well as whether they reported discrimination. And then the y-axis is the probability that participants in that group attributed discrimination to a particular characteristic. I'm going to sort of stay out of the weeds of the graph, but what we can see here in a big picture way is that we have 4 groups of participants in this particular city, which is New Haven, Connecticut. And these groups of people are differing based on how many attributions for discrimination that they're making and what these attributions are. So the top line tells us that we've got one pretty small group of participants, about 4% of our sample, reporting that they've experienced discrimination, and then they're making attributions to a lot of different characteristics for that discrimination. The second group from the top tells us that we have another group, which was slightly larger at 16%, reporting that they've experienced discrimination, and many of these participants are saying that it was due to their race, gender, income, and or age. The third line represents the largest group in this sample, which was 44%. They said that they did experience discrimination, and most just attributed it to one characteristic, which may have been race, ethnicity, or income. Those were the most popularly chosen attributions. And then we've actually got a sizable group of participants in New Haven, Connecticut, about 36%, who are saying that they haven't experienced discrimination, and so they also didn't make any attributions for discrimination. So stepping back overall, this type of approach can help us to characterize how subgroups within a community may be experiencing intersectional and sort of experiencing stigma in an intersectional way or through an intersectionality lens. And then we might want to consider these subgroups of people when we're developing our intervention strategies. Now, Turan's paper describes additional approaches to intersectionality, including multilevel modeling and structural equation modeling. I'm going to stop here, though, and let you read about those so we can address some other critiques of stigma research. I would like to highlight that a really critical point that Turan's paper raises is that every approach to intersectionality research has both strengths and limitations. just like every measurement approach that we have and pretty much every, methods approach that we might have. So you should consider your strategy for studying intersectionality in relation to your specific research questions and the type of study that you're conducting. So there's a really nice table in the paper, it's table 1, that summarizes all of these different strategies for modeling intersectional stigma and then includes recommendations for each approach. So if you're trying to think of, I have a research study, I have some research questions, and I'm not sure how to measure intersectionality within the context of that study, I'd really encourage you to go to Janet Tran's and colleagues' paper and think about what makes sense within the context of your work. Okay, last step. Much of our stigma research has historically disregarded context. This is the conceptual framework that I presented at the beginning of the presentation, linking the social process of stigma with downstream health outcomes. So importantly, this framework was missing context. The institutions, the communities, and the societies in which individuals live and experience stigma. So the context in which people experience stigma can actually vary quite a bit. So let's just think for a moment about how HIV criminalization laws vary throughout the United States. So these are laws that criminalize behaviors and behaviors that expose other people to HIV or increase sentencing lengths when a person commits a certain crime while infected with HIV. So here's a 2019 map of the distribution of these laws for the Center for HIV Law and Policy. And again, I just mostly want to draw your attention to the variability. So these laws, which have been argued to be a form of structural stigma, vary state by state. So this means that the risk of incarceration for people living with HIV, which has important implications for health outcomes, also varies for people living with HIV state by state. And then it's also possible that a person living with HIV, with more HIV-specific criminal laws may experience enacted, anticipated, and internalized stigma differently than a person in a state without those laws. They may worry more about stigma. They may find that the people around them endorse and enact more stigma, more prejudice, stereotypes, or discrimination, and the consequences of stigma may be worse than them. So our environments can have a big impact on our health directly, as well as through the ways that we're individually experiencing stigma. Mark Hatzenbuehler and Bruce Link have co-edited a special issue on structural stigma in 2014 in Social Science and Medicine. And this includes papers examining associations between structural stigma and health outcomes. It includes articles from different research silos, which is really nice, and highlights studies that use different methodological approaches to studying structural stigma. So this is a terrific resource if you're interested in studying structural stigma. The special issue offers up a definition of structural stigma, which is societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. So examples of structural stigma that could potentially be operationalized and then used within our analyses, including as independent variables predicting health outcomes, could include things like the existence of federal, state, and local laws, as well as institutional policies, such as the HIV criminalization laws, and we can look at those in relation to health outcomes. We can also look at community-level social norms and attitudes, which can sometimes be pulled out of our national social surveys. We can look at contextual events, things that happen, including, as an example, what ensued after 9/11 for Arab Americans. We can look at area-level hate crimes towards stigmatized groups, assuming those data are collected. And we can also look at disparities in judicial treatment or political participation, which has been studied quite a bit in the context of racism. Now, essentially, these indicators can be treated as independent variables in our analyses predicting health outcomes. Now, work on structural stigma looks at associations between individual indicators of structural stigma and health, such as one law or one event, and I'll share an example next of a contextual event. But work has also looked at associations between indexes of structural stigma and health. So these indexes often combine several of these indicators of structural stigma into one variable. And a benefit of that is that they'll have greater variability than just one indicator alone. So Hudson-Buehler identifies two primary methodological approaches to studying structural stigma and health. The first is to look at associations between population-level stigma indicators with population-level health outcomes. And the second is to look at associations between population-level stigma indicators with individual-level health outcomes. Now, in this second case, multi-level modeling is suggested to enable researchers to look at how a contextual level factor, a population-level stigma indicator, is associated with those individual-level health outcomes. Dr. Hudson-Buehler wrote a chapter in the Oxford Handbook on Stigma, Discrimination, and Health that does a really deep dive into these methodological issues. So I'd very much recommend reading that chapter if you are interested in learning more about these approaches. But before we move on, I'll just highlight a recent example of a study from Dr. Hudson-Buehler and colleagues' work. So the study focused on Proposition 8, which was a voter referendum in California to restrict marriage to heterosexuals that was voted on in 2008. So Hudson-Buehler and colleagues found that students reported more homophobic bullying leading up to the Proposition 8 vote, which is represented by that vertical line in the middle of the graph. And then they reported less bullying after. And they also saw that this trend was worse for students in schools with no gay-straight alliances. In the graph here, the red line on top represents the schools with no gay-straight alliances, and the blue line represents schools with gay-straight alliances. So you can see that the red line, schools with gay-straight alliances, are indicating slightly higher rates of homophobic bullying. So in this study, Hudson-Buehler and colleagues used aggregated school-level rates of bullying in this analysis. So this is an example of linking a population-level stigma indicator, the timing of the Proposition 8 vote, with a population-level outcome, aggregated rates of bullying. I think that this is a nice example because it shows how what we might think of as an individual level experience of stigma, even though it was measured in an aggregated form, but which was homophobic bullying, experiences of bullying, may be shaped or influenced by what's happening in people's environments. We also know that bullying is associated with all sorts of negative health outcomes, so we could hypothesize that this Proposition 8 vote may have also had an impact on students' health. Okay, we'll wrap up today by thinking briefly about the Stigma Intervention Toolkit. Now, what do I mean by Stigma Intervention Toolkit? And I'd like to emphasize here that this toolkit frame has been used and introduced by some really smart colleagues like Anne Stengel and Stephanie Shador. So the idea here is that right now we don't necessarily have, a single silver bullet to cure stigma. Just like we might argue that we don't yet have a single cure for substance use disorders or maybe for obesity. But we do have many tools in the Stigma Intervention Toolkit. In other words, we have developed a sense of strategies that appear to work to decrease stigma. We had tools to address stigma among individuals who are living with stigmatized characteristics, including people living with HIV and substance use disorders, and also among people who may perpetuate stigma, and within our organizations and institutions. We also have a sense of how we might need to implement these strategies or to use these tools in ways that might make them more effective. So we know that intersectional or cross-cutting approaches, longitudinal and multi-level approaches appear to be more effective. So I'm going to highlight just a few of these tools for us. For targets of stigma, I often think about bolstering resilience resources. So these include modifiable, strength-based characteristics that can buffer or protect people from the negative impact of stigma on health outcomes. Examples here might include empowerment, social support, and adaptive coping interventions. Now, the idea here is basically that it may take stigma a while to change. We know that it's this broad social process that involves a lot of these different moving parts. So it's important for us to think about how to protect people from stigma while we all work to change it. The Unity trial is an example of a resilience building intervention for African American women living with HIV. So this trial incorporated different intervention tools, including education, contact, counseling strategies, and coping skills. And the investigators found that participation in the Unity trial was associated with greater engagement and care among some of the subgroups of women involved in the trial. We can also work on reducing stigma among members of the general public and within our structures. So some of our tools for reducing stigma among these groups include, again, contact, education, policy changes, and communicating diversity values. Of these, I'd like to just highlight contact for a moment because it's one of the most well-studied tools that we have to reduce stigma. So contact can happen either in person or vicariously through the media, like through TV, the radio, podcasts, or books. And research suggests that contact leads to increased empathy and perspective taking with stigmatized individuals, that it also leads to enhanced knowledge, which can lead people to question their stereotypes, and it leads to reduced anxiety about interacting with stigmatized individuals in the future. And then in turn, this can lead to lower prejudice or improved feelings towards people with stigmatized identities. And lower prejudice paired with reduced stereotypes can lead to less discrimination, which is often our goal for stigma reduction. Now, if we think about the big picture for stigma reduction intervention, I think that there's growing recognition that our stigma interventions to be most effective should be multi-level. So they should include or they should target changes at the structural, interpersonal, and individual levels to be really maximally effective. And this is really important because we know that stigma lives at all of these levels. Of course, you know, this isn't always feasible to pair building resilience resources. Sorry, I think I've got some background noise out there. So it's not always possible to build, to accomplish structural level change when, you know, within the interventions that we're doing as researchers. But the theory suggests that our intervention should encompass all of these levels to be maximally effective, but we do the best that we can. We also may want to use multiple tools from our toolbox to address stigma. Evidence also suggests that it can be useful for our interventions to be intersectional or cross-cutting in nature. That is, they don't just target one stigmatized characteristic or identity, but cut across different stigmatized characteristics. Now, this is important because we know that different kinds of stigma are often related. So someone who feels prejudice towards people living with HIV in some of our studies may also experience more prejudice towards people who inject drugs and men who have sex with men. And also, people often live with more than one stigmatized characteristic. So I think that there's a movement toward considering multiple stigmatized characteristics within our interventions. And there's also some evidence that stigma intervention should be longitudinal in nature. So in general, one-time interventions don't appear to make a big changes in stigma unless they are these big policy changes. So I'll end by noting that stigma research can be challenging, in part because people aren't always clear on what we mean by stigma or how it manifests among individuals. We're essentially studying a social process. But luckily, I think that we have many measures and methods that we can use to answer important questions about stigma, including how people experience it and how it affects people's health. And as a field, we are growing our toolbox for addressing stigma and uncovering ways to best use these tools. So I think that it's a good time to be a stigma researcher. So I'd like to sincerely thank you all for tuning in and also, more importantly, to contributing to research in this area. I think that the more people doing stigma research, the faster we'll find solutions to improve people's well-being. So I'm happy to take questions, and I'd just like to apologize if you're hearing any noise here from the outdoors.
Thank you, Valerie, very much. We would also apologize for the noise that I'm sure everybody is hearing. I understand there's construction going on in your building, and nothing could be done about it, but it's certainly been there in the background for our audience today. A number of questions have come in, and so let me jump into those. How active is NIH in supporting research related to stigma? And are there FOAs that you're aware of that invite research related to stigma? Which of the institutes and centers perhaps are most actively involved? So let me just ask that to start with.
Great. I have found, good luck at NIH, or I found NIH to be supportive of stigma research. So within HIV specifically, there's been a call for applications focused on R21s for stigma in addressing HIV stigma specifically, but I think there's some interest in intersectionality within low and middle income countries. And then there has been specific calls for research on intersectional stigma research, really trying to crack this question of how do we measure intersectionality and how do we, and what methods can we use to address or to study intersectionality within our research. So, a lot of my research and my background is in HIV, and I think that there's been some really terrific support for stigma research. And there's also a good track record of funding interventions to address HIV stigma, both among targets of stigma as well as people living with HIV, as well as some key sort of perpetrators who such as healthcare providers who may have a larger impact on people's health.
All right, I think offline we will try to get information from you about specific FOAs or other announcements so that we can put them on the website and people can understand what they are. Based on your own experience and your conversations with others working on this kind of topic, what have been the issues raised in the review of applications that have been problematic in terms of getting research support?
So lately, I think that intersectionality does come up a lot. And I think that it comes up a lot because there's this recognition that people are intersectional, that if you're studying HIV stigma, that that stigma or your experiences may be also shaped by your gender, your sexual orientation, your race. And I think that people have been encouraged to account for intersectionality within their research. But then at the same point, we understand, or we're starting to understand and think that it's important. But then at the same point, I think our methods have lagged behind our understanding of the importance of looking at it. And so, I think what is probably, hopefully useful in an application, what I hear is useful, is to really, as I noted earlier, to ground, because there are so many approaches to studying intersectionality, is to really ground your either measurement and or methodological approach to data analysis within whatever research question that you have, and really make a clear case for why this is the way that makes sense to study it within your study. Because I think that there are pros and cons of most ways that we could study intersectionality. So I know that that's something that comes up quite a bit. Another thing that I think can be challenging is things like contact are some of our best interventions for reducing stigma, including among healthcare workers. But then the question might come up, how safe is it to facilitate contact between stigmatized individuals and healthcare providers or other types of people in places where the structural stigma is really quite strong, where there may be criminalization laws, where people might be at risk of going to jail or being fined or assaulted if it's known that they're a member of a sexual minority or that they have a sexual minority orientation or something like that. So I think that's what's challenging about that is, some of our best tools for stigma reduction become, ethically challenging and worth a conversation in some settings. And I see that being something that, both investigators and reviewers sometimes grapple with.
Thank you. You've spoken quite a bit about stigma as it relates to HIV, to substance use. We have a number of people watching the webinar who work in other areas like obesity research, where there can also be stigma. Would you encourage people to use a general measure like the everyday discrimination scale? Would you recommend that they try to adapt existing tailored measures to work specifically with obesity, for example, or some other topic? How would you guide investigators who work in other content areas?
Thanks. This is actually a question that I think about a lot and talk to fellow stigma measurement people about a lot as well. So there's pros and cons of both approaches. Some of the pros of a generalist approach of taking something like the everyday discrimination scale and using it in your research is that you can compare it to other studies. It's a validated scale. You can kind of get up and going really quickly. You can also use it, something like the everyday discrimination, to measure, multiple or stigma associated with multiple characteristics at one time. So there's some pros to that. What I think we're starting to see, though, is that these more tailored scales that get at the specific experiences of stigma that people are having, that those are more potentially powerful predictors because they're more nuanced. It's sort of like our telescope is better focused on the planet that we're looking at. And so if it really matters to, stigma is one of the primary questions. If it really matters to researchers to deeply understand the extent to which people are experiencing stigma and the effect of that stigma on people's health, then taking the time to develop a more tailored, specific measure may be worth it for them.
Do we have data on the cost of stigma in terms of healthcare costs or healthcare delivery costs?
That's an excellent question. I'm not sure off the top of my head, although I would really love to know if anyone out there is listening and does have an answer to that. We know that stigma undermines people's health behaviors. Taking it back to the context of HIV, we know that internalized stigma undermines antiretroviral initiation. And so to the extent that people aren't getting their medications, that will have a downstream healthcare cost. But I haven't seen anyone put a number on it off the top of my head, although I think that'd be really interesting to see.
We had a question from someone who was interested in that, so maybe we'll get some work started in that area. We are out of time, and so I will turn things back over to Marie to close us out.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.